few weeks ago, we talked about GLP-1s, and today we're jumping back into the conversation because it's clear this topic isn't slowing down. If anything, it's getting messier, louder, and more confusing by the day. Semaglutide, Tirzepatide, Ozempic, Wegovy, Zepbound, whatever name you know them by, these drugs have exploded across the country. And honestly, so has the confusion, the misinformation, the flat-out reckless prescribing.
Yeah, we're actually seeing people get these meds out of med spas, out of strip mall clinics, even out of syringes handed from a refrigerator. And that's not weight management, that's actually chaos. Meanwhile, you've got patients who generally need this medication but cannot access it, can't afford it, or don't even know who to trust.
So today we're breaking it all down. What GLP-1s actually do, where they help, where they go wrong, why some patients fail them, why some thrive, and what a safe medical weight loss program should actually look like, from dosing to labs to nutrition to monitoring. All right, Dr. Parker, I'm going to give you a statistic.
Okay.
How much do you think the market for GLP-1 weight loss medications is projected to be in 5 years?
In other words, how many people are going to be on this?
How much will it? Yeah, well, I mean, we assume that the price is going to go down. How much do you think the market will be? It's projected to be.
I have no idea.
$200 billion.
Holy cow.
Essentially, these medication, class of medication, GLP-1 medications, are essentially going to be their own economy.
Aren't you glad we have stock?
I'm
just kidding.
I don't know. Yeah. For the people that are questioning if Dodgers are in the pockets of pharmacy, we do not own stock in these things.
That's insane.
Yeah, $200 billion. Wow. I mean, essentially, that's the GDP of like a lot of countries.
Yeah.
So it's crazy.
Well, I know we've talked a lot about this, and it's been interesting to see the trend even in the last several months on where these medications are going. Yeah, what are your thoughts?
So, you and I, we have our clinics. We both have GLP weight loss programs at our clinic. So I'm in full disclosure. Part of the reason why we did the GLP-1 weight loss program was people were asking about it.
Mm-hmm.
And when we did a little bit of research into what's available in Tampa, we were like, this is ridiculous.
Mm-hmm.
Like, this is the wild, wild west out here.
Yeah.
You could go on a street just down the street from where we are, and you can go to like these med spas, and they're selling vials of GLP-1 weight loss medications in syringes.
Crazy.
So think about how ridiculous that is. The benefit of GLP weight loss medication, in particular, like Ozempic, also known as Semaglutide, Tirzepatide, also known as Mounjaro.
Mm-hmm.
The benefit is long-term, right?
Mm-hmm.
If somebody goes to a clinic and says, here's your injection, this should be good for like a while, and then like they can't afford it afterwards, but they come back. Each of those vials are supposedly anywhere between $100 and $125, right? So that's 4 to 5 times the price of the actual dose.
Right.
Not only are they expensive, taking advantage of them, they're taking advantage of their like understanding of this medication. Right. And frankly, contributing to a little bit of eating disorders, right? Because this medication is going to prevent them from eating. Here you go. Here's a shot. Give me $150 and don't eat for the next week.
Is anyone actually saying, no, you're not a candidate for this drug?
No one is doing that. No one is doing that. We had a patient who came into our clinic. She Googled us and she was driving. And when she saw our name on there, she said, I need to go and get a syringe. And Neer's like, wow, why do you need a syringe? I don't get it. And she's like, don't you just have like syringes in your fridge? And she's like, we don't do that. Like ours is a program. We work with you.
Right.
And she's like, well, that's what they're doing all over the place. And so we did a little research into it, and we kind of investigate like what's going on. This is a very common practice where you can go onto some med spa, get a medication that is not even prescribed by a certified physician or a board of a certified physician. Just get it and, inject yourself and move on.
Scary.
What's really interesting about this, and we heard this from some of the pharmacies, is that they dilute the medication. They'll say that they're prescribing
a certain amount,
certain dose, and what they're really doing is providing a lesser dose. And then they'll fill it with a vitamin of some sort, or they'll fill it with maybe some sterile water or something.
So if you're the patient, the consumer, how do you know?
You don't.
How do you trust?
So that's what I think that's the difference between a program like yourself, a program like myself, where you are coming to the clinic, you're getting weighed, you're getting labs checked, your physician is examining you, follow up every month, working with a dietitian.
Right.
Like that's how you do it right.
Maybe a little harder, but I think it validates it so much. I mean, as I mentioned in our last podcast several months ago, I think this is a miracle drug. I think this is a miracle molecule. I think it has helped a lot of patients. It's interesting to see all the benefits that are potentially out there now. But I also think you need to go through the proper channels and be monitored very closely for this, because as I have seen, they can have their consequences.
So when you have a patient who comes into your clinic asking for medical weight loss, can you walk me through what you guys do?
Yeah. So first of all, they're screened pretty heavily. There's actually a form that they fill out at home. It's a 3 or 4 page assessment on their history and what dieting strategies have they used in the past? Have they been on medications in the past? What's worked? What hasn't worked? The big things I want to screen out for is, have you ever had a history of pancreatitis? Is there any family history of carcinoid MEN tumors?
Medullary thyroid cancer.
Yeah, they may not know, but and at the end of the day, if they check the boxes, at least on paper, they're invited to come in and actually sit down with the physician to actually look at their vital signs and see where they're at with their BMI. If you are 1 pound away from disappearing as it is, you're not going to get this drug, right? So there are many patients who want it because it's almost taboo. Well, my friend is on it, this friend is on it, and I want to be on it. But no, I mean, this medicine does have its consequences if used inappropriately. So we do a really good job of screening. Same way we do.
I mean, I think we copied your screening methods. So we do a lot of that. When I sit down with the patients, I like to educate them about how that medication is going to work. So part of the screening is like, are you going to tolerate it? What I don't want is them to be miserable on the medication.
Yeah.
We had a patient who was like very worried about nausea. And honestly, we trialed it. We trialed it with the lowest dose. The nausea persisted for the first week and it worked out. After that, the nausea persisted. And at that point, I'm like, on the lowest dose of medication, if you're this nauseous and you're not eating, this is not a safe option for you.
Right.
Yeah, fine. You're going to lose a lot of weight. You're also going to lose a lot of muscle. And you're going to wither away, and it's going to contribute to your misery and potential eating disorder. I don't think that's a safe thing for you.
Are you seeing a lot of good results with your patients?
Yeah. I am surprised at the effect of this medication.
Right.
So I was talking about this with Andreas. Sometimes we have to like encourage the patients to eat.
Right.
I had a patient who came in and her sister was losing a lot of weight, and she's very, very thin, and she knows what bad weight loss looks like, right? And so she's like, I don't want to do it like my sister. I don't want to lose too much weight. I just want to do it slowly. I want to look appropriate, this and that. I said, I totally understand. We'll work with it. Our goal is 1 to 2 pounds per week. I weigh you every week. I want to know your diet. I want to talk about it, that kind of thing.
And I say you have to put in your best efforts as well. This is not, you need to have a strategy.
Yeah,
you know?
exactly.
And that's the other thing in the screening. I want to know, do you have a plan in place? Are you working with a nutritionist? Are you working, out at a gym? What are you doing?
Right.
And then I like them to prove it to me.
Right.
So in their follow-ups, show me that you, in your in-body, what you've done.
Right. Right. So
that holds them accountable.
Yeah, exactly. And so the patient that I was working with, she's like, I'm just so tired. I'm just so tired.
Mm-hmm.
And like,
there's no energy. There's no calories.
You're not eating. And like, she's got other things going on. She's a very active person. And she's just like, I'm just so fatigued. I'm just so tired. So then I walk through it and I'm like, so what are you eating in a day? And she tells me what she's eating. And she's like, well, I try to stay away from carbs and I stay away from this and I stay away from that. I'm like, what are you eating? Well, I basically ate about 800 to 1,000 calories a day. I'm like, and then that's when you sit down with them. You talk about their basal metabolic rate. I said, like, just to be alive, you need this many calories. And like, you're burning off more than what you're taking in. Yes, you're losing weight, but you're losing muscle and fat and you're exhausted.
Right. And I really push the creatine. I think there's a lot of good studies to show how beneficial creatine is for the body and the muscles. And, patients that I am seeing some muscle wasting, muscle loss, I absolutely am quick to put on 5 to 10 grams of creatine. So, and that can help.
Yeah. Now, I guess my response to that is I won't recommend it unless they're doing resistance training.
Yeah.
I think the part I would say in this part is they have to first start working out.
Yeah.
I know a lot of people are pushing the creatine stuff, and I am supportive of
and the protein. Make sure they're getting protein.
And I'm supportive of the creatine too. But I've been taking creatine since I was like 18 years old. Like, if you don't...
No wonder you're so smart.
Yeah, right. If you don't lift, don't do nothing. You just urinate it out.
Yeah.
So, there's a lot of good parts to it. I see it.
Yeah.
But creatine needs to be consumed with exercise.
Do you have patients that are not responding very well?
Yes. I struggle a lot with that. We have patients who are on very, very high doses and they are almost plateauing.
What's a high dose?
So through a Tirzepatide, you're looking at 15 milligrams. And that would be the highest dose that's available. And we even tried changing formulations with a different pharmacy. And it still was non-effective.
Is this primarily in morbidly obese patients? So either they become refractory, like were they losing weight and then did not?
That's exactly what it is. I wouldn't describe...
They've lost weight.
They lost weight.
Plateaued, and they still have a lot more weight loss.
Yeah, they could, maybe not extensive, but some weight loss.
Okay.
But the issue that I'm experiencing is, and I think this is where the plateau of this whole treatment program is going to be, is when people are using it for like just lifestyle.
Right.
Like, I still want to go and party. I still want to go have a good time. I still want to have drinks on the weekend. I still want to go to all the restaurants. I'm just going to take this, but I won't be as bad as I used to.
Yeah.
Like, well, then you're not going to lose weight.
Yeah.
Right? So you can't come to the clinic and then be surprised that your weight...
Because I think we're all lazy at some aspect.
Yeah.
If they're not putting in the effort and they're just taking in this medicine. I mean, you've got to work at it.
Now, on that being said, it's a reasonable method to not get worsened, right? But like, I have a personal problem with, maybe this is just me, but like taking a high dose medication to keep yourself stable so that you can, still have, alcohol and random, like, that just doesn't make sense to me.
Right.
Maybe that's just something I have to like get through. But I don't understand. That's like, it's a means to still having a good time, but without blowing the scale. And then I think that's something that needs to be addressed. And that's maybe something in the clinic that we can...
Do you have a strategy for patients that are not losing weight then?
Yeah. So my first strategy is to see the medication. I was taught in medical school by this like very, very intelligent endocrinologist, and he had like these laws, and it was Dr. Newman's laws. They still to this day, they're brilliant. But the first one was blame the drug until proven otherwise.
Yeah.
And so every day I ever look at any patient with their meds, like blame the drug until proven otherwise. So I always follow that law. So as the
I have to interrupt here. Did you ever watch House?
Yeah.
Did you ever see that episode? It reminded me. There's an episode where he is interviewing a patient. She has pretty significant asthma and she's not getting any better. And he says, "Can you show me how to use your inhaler?"
Yeah.
And she says, "What, do you think I'm stupid? Of course I know how to use my inhaler." And he says, "Show me."
Yeah.
And so she pulls out her inhaler and is using it as a perfume. So, touche.
All right. You want to know something really funny about that? When I was a kid and I was in my 20s, I had really bad asthma. And I was at like a dinner and I was having an asthma attack, and I took my inhaler and I pulled it out and I puffed it, and then because you could see the smoke, and I inhaled it. And a pharmacist saw me doing it. He's like, "What are you doing?" And I'm like, "What?" And I'm like, "I'm taking the medication." And he's like, "Half it's going into the air." He's like, "No wonder you're wasting half this medication." I was like, "Of course none of this thing's work. You're not taking it inside." So when I saw that House episode, I was like,
Yeah.
That's about as close. Hey, it's home.
So true. But I do the same thing. Blame the medicine. Right?
Yeah. So I blame the medication first. And then the second thing is you got to think about some of the stressors in that person's life. So what are the issues that are curtailing their life? And I actually go and do a deep dive into like, what's the diet look like? And frankly, no one's ever really honest about that sort of situation. Like they don't, and it's not that they're not being truthful. It's that they may not realize that some of their dietary choices are not perfect.
Yeah.
And then the third option is, and I always stress this, is what's the booze intake? Like alcohol is the number one cause of failure in that GLP in my patients.
Yeah.
Every one of my patients that gain weight is because they drink 3 beers, and they don't realize like that tall beer is like 400 calories. You drink 3 of that. I mean, that's a pound of weight you're going to gain, right? Yeah, it's a couple beers. So what? So that's the consequence.
Yeah.
Then the fourth thing, and this is actually the thing that I've started to really get to the bottom of, is trying to understand like their anxiety and their depression and their eating issues. Are they eating because they're anxious? Are they eating because it's habit? Are they eating because they have social stressors and like they're in public areas and they feel like they need to? Who every time she drove by the McDonald's had to go through the drive-through. It was just this like extreme need.
Wow. And
I'm gonna be honest with you, there was a time in my life when I used to research in a research hospital. And this hospital, I used to take the bus, and the bus dropped me off at this parking lot. I had to walk through this McDonald's parking lot, and I cannot tell you the drive that I used to have to just walk inside and grab. No, but I had no money, right? I was like a kid, so that's the only thing that limited it out. If I had like maybe $1.50, I was like, I'm going in there.
Wow.
So so I understand that, and there's subconscious drive. There's all sorts of things associated with it. So I've started working with a psychologist in our patients. I asked them to work with them. I started a patient on an SSRI to work on their anxiety.
You ever thought about like Wellbutrin?
Yeah, that was it. There's another one, Contrary, which is a naltrexone, bupropion combination.
Yeah.
It cuts some of their
cravings.
Yeah, cravings, and so that's something that we've used and utilized, and actually that actually works a little bit better. That's actually the one, because you have to get to the bottom of like, why is the weight loss not happening? And what I've noticed is the cravings is the big issue in those patients.
Would you add phentermine?
Yeah, no. And I say that because I don't like anything that is a stimulant of
Right.
some sort.
Right.
Yeah, phentermine has benefits, and I'm sure it's fine. It works, and
There's some newer studies that, because the way I was trained and what I learned is, it's used very short term.
yeah,
And many patients have that rebound weight gain when you come off of it.
right.
But there are some newer studies to show that long-term use may also have their benefits.
Yeah.
But I'm like you, I'm very nervous.
Yeah, like so a couple of the weight loss clinics that I used to work with in years ago, they used to use phentermine very commonly, and I talked to some of the patients on it, and it felt very, I don't know,
Yeah.
methamphetamine-ish, experience, like a stimulant,
Right.
very pacing heart rate, sometimes worsen their anxiety, and I'm like, oh, this doesn't sound like a good option.
Yeah.
And then there's the other one was metformin, when they would put patients on metformin, and I actually just read a study that long-term metformin was not beneficial in weight loss, but that could just be an observational study. But yeah, like it decreases appetite and stuff. But
I have, in a few select cases, whether, if the patient is really, really obese and they have hit a plateau, there's two things that I've done. One is, let's just go on a drug holiday. Let's stop the drug. Let's see if things, let's just reset. And then I'll add it back at a lower dose, and then we'll build up again. And sometimes that has been enough to kind of get things jolted. I have also actually increased the dose beyond what is currently available as the maximum therapy. So extending it to 17.5 milligrams through a compounding pharmacy, or even bumping it up to 20 milligrams.
Jeez, really?
I have seen some.
I mean, it makes sense because, like, if the receptors are down-regulated, then, you need to give them more medication.
Right.
Sorry, they're upregulated, so you need to give them more medication for the effect to work.
Yeah.
It makes sense from a pharmacokinetics standpoint.
Yeah.
I guess the point that I get to is, like, if it's not working, it's not always the drug. It's, it's multifactorial. And I think everybody who has weight issues understands that it's not just this simple thing. And anytime somebody says it's just because you're eating too much, well, that's ignorance about the problem.
Yeah. Talk to me about access and some things that have come out recently. Are you finding it easier to make this available for your patients?
Yeah, I mean, I would argue it's the most accessible medication right now, or other than over-the-counter medications. I think it's too accessible. I think it's too risky right now in certain places.
For these cash-paying patients, correct?
Yeah.
What about insurances paying for these?
Well, insurances do not want to pay for it. And I'll tell you the reason why. It's because it's actually very simple. Eli Lilly and Novo Nordisk, which own the patents for the GLP-1 medications, they don't want to lower the price, right? And the FDA has put indications for diabetes on these patients, so they're gonna pay out those prescriptions.
It's even sometimes difficult to get those diabetics on these meds as well.
Yeah, so, like, people talk about what's going on right now, and, like, there's a lot of blame to be had about why insurance premiums are rising. Well, when 9% of your budget is GLP, that's the reason why premiums could potentially be going up too. So these are also the effects. So fast forward what happened with Human Health Services and the White House saying that they was going to lower prices. Right. I mean, that sounds all great, but I want you to think about it from a insurance standpoint. What's the largest insurance company? What's the largest insurance program in the United States of America? It's Medicare and Medicaid, right? Those are public insurances, right? So they just negotiated with those companies basically by gun. They're like, you have to lower the price, and essentially, like, that's how they negotiate. Like, you are going to do it or not. And so, Medicare patients are going to be down to 50%, or $50, I think, a month. Medicaid patients are going to be down to $50 a month. That sounds amazing. let's wait and see. I've heard government tends to say a lot of things.
Commercial insurance, not so much.
Yeah, so there's nothing about commercial insurance.
Yeah.
And you cannot force a commercial insurance to cover it. It would essentially bankrupt them.
Yeah.
And Eli Lilly and Novo Nordisk aren't really willing to drop the pricing down right now. Why would they when there's projected $200 billion coming to their coffers, right? So this is a simple math question. Are they going to do it? Maybe. We'll see.
Yeah.
But
Zepbound, which is
Tirzepatide,
but really indicated for weight loss, whereas Mounjaro is indicated more for type 2 diabetes. There is a new indication that if you meet criteria for obstructive sleep apnea, that they should provide benefits. But
I've had 2 patients that have applied for it and have not gotten it.
So there is a way. You cannot mention anything about weight loss in the prior authorization.
Really?
And you have, depending on the commercial insurance, they have to at least have moderate to severe obstructive sleep apnea. Mild sleep apnea may not completely cut it. And there's certain verbiage that you have to include. But I've not had as much difficulty with some commercial insurances. But I don't mention it's for weight loss. I mention it's to treat sleep apnea.
That's actually super helpful. I have a patient who I'm going to try that for.
Yeah.
No,
and if you have issues, just call Kristen.
Yeah.
In the office. She can walk you through how to do it or walk you right through it.
Interesting.
Yeah. So, but you cannot mention anything about weight loss.
Yeah.
And even then, I have noticed it's still very expensive.
Is it really?
It's
I thought it was covered in insurance and there's...
Well, if you look at actually what they're charging for a cash price,
yeah.
If insurance pays for it, it may bring it down to $500. I don't
That's
think
super expensive. You want to know something that's really interesting? That Eli Lilly program,
the Eli Lilly Direct.
Yeah, that's still super expensive.
So for the 2.5 milligrams, it's $4.99. It doesn't come in that self-injecting pen. You're getting vials.
Okay, so it's the same thing.
It's the same thing as.
So if you go on the website, it says $4.99 till every dose, including 15 milligrams of Tirzepatide. So I was like, oh, that's crazy. Like they're willing to do this. But you still have to do a membership program, right? You still have to do telehealth with them. That has to be built through insurance. So that's going through their deductible, right? That is going through it. So essentially it's not $4.99. It's like $600 to $700
through their program. If you select the cash pay option, you can bypass all that. So if patients are just willing to pay the cash price, all I do is send in the prescription. Patients get notified, they submit their payment to Eli Lilly Direct, and then Eli Lilly Direct drop ships it to their address.
Interesting. So it's $4.99 for whatever dose.
$4.99 for the lowest dose and $4.99 for the 5 milligrams. I believe it goes up $100.
No, as of like last month, it's the same now.
Got it.
Throughout.
Okay.
I was just on the website because I was like just trying to figure it out because one of our patients questioned. She said, what if it's the compound pharmacy one? Maybe it's not effective. And I was like, that's a good idea. Let's look at different options.
Yeah.
And when you get up to a high dose with the compound pharmacy, it gets very expensive.
Very much.
Right. So so $4.99 actually would be no risk necessarily for that patient.
Yeah. Would you ever consider giving these medicines? When I say these medicines, specifically Ozempic, would you consider giving that drug just merely for its cardioprotective benefits?
Yeah, I mean, it makes sense. So now that's a really good question because, in the congestive heart failure world, we used to have, beta blockers, ACE inhibitors, like statins for something, long-acting nitrates, hydralazine if they couldn't have lisinopril. But there were certain medications that we'd use. And then, then there was other medication that came up, and these were SGLT2 medications, and they showed to have significant benefit in patients who were not only had systolic heart failure, but also diastolic heart failure.
Right.
And what's really great about that is prior to that, there was no other medications for those options. So that was like a really great option. From what I understand, semaglutide has not been seem to differentiate between systolic and diastolic. I could be wrong about that, but they did say there's cardiac benefit from it.
Yeah.
So,
Well, and one would think it's because of the weight loss, right?
yeah.
So it seems everything should improve when there is weight loss. But it was interesting in their trial, weight loss certainly explained a large share of their cardiovascular benefit, but multiple lines of evidence suggested that Ozempic directly had weight independent cardioprotective benefits.
Right.
So
I think going back into that, what are the cardioprotective benefits from there? So is it the molecule of the GLP-1 medication that's protective of the heart? I don't buy too much of that.
yeah.
Even in the discussion of that study, they reflect on the reduction of certain adipose tissues that can accelerate
Mm-hmm.
cardiovascular disease, right?
Yeah.
So it makes sense. It obviously makes sense that certain adipose tissues could be hyperinflammatory, causing what's called that high sensitivity, high reactive CRP to be elevated. That could be it. And we know that those kind of have relation to cardiometabolic and cardiovascular disease.
Yeah.
So there's a ton of nuance with it. But I mean, I'm not a betting man, but if I was betting, it's because of the massive amount of weight loss.
The makers of Ozempic really tout this benefit. I can't help but think that Tirzepatide also has the benefit. We don't have that information yet. I think it's promising, but it'll be interesting to see because ultimately Ozempic has more GLP. If we truly think it is a molecule effect, Ozempic has more GLP activity as opposed to Mounjaro that has more GIP activity. So it'll be interesting to see what the future holds.
So let's talk a little bit about like the Mounjaro or the Zepbound, the world. Like, okay, so let's call them their trade name, Tirzepatide versus Semaglutide. Gun to your head, you got to choose one.
Mm-hmm.
Which one would you go for?
Mounjaro.
Yeah. Really? I would not have guessed.
Mounjaro over Ozempic or?
No, sorry, Semaglutide versus Tirzepatide.
Oh, yeah, Tirzepatide.
Okay,
I'm sorry. Hands down, Tirzepatide.
Yeah, me too. And it's
before Tirzepatide, the Mounjaro Zepbounds of the world. I thought Ozempic was great.
Yeah,
it was a miracle drug. I used it for years. I saw weight loss. And then the minute Tirzepatide came out, it was a game changer.
It is.
Difference.
It works so much more effectively. The symptoms are significantly less.
Mm-hmm.
And I would argue that patients are utilizing I don't know why, but they have better behaviors on it. Like the Semaglutide ones, the patients that I've experienced with it, they just didn't eat.
Yeah.
But the Tirzepatide patients, they have better eating habits because they're not nauseous and they think twice about certain experiences. But I don't know if that's.
Have you had any situations that came up that you felt was a direct effect of the medication negatively on the patient? In other words, have you seen?
Yeah, I've seen it in the hospital. Yeah. So I had one diagnosis of pancreatitis, which was related to Tirzepatide. Not Tirzepatide. It was Semaglutide.
Okay. Early on in the treatment, or
it was early. It was early on, and it was at a dose much higher than she should have been started on.
Mm-hmm.
So I did see one diagnosis of that. There was that one, and then there was one diagnosis that somebody called it a small bowel obstruction, but small bowel obstructions don't happen with GLP-1 medications. Abdominal distension does, gas does,
maybe it's
reflux.
A consequence of chronic constipation that can be a side effect.
Yeah.
I do see that a lot. I've seen many people have biliary dyskinesia, whether they were set up to have it in general, but I've seen a lot more people getting their gallbladders removed.
Yeah.
Now that they've been on the medication. So
I will say this, I do use Semaglutide, in patients who have difficulty paying for the tirzepatide
Mhm.
because the semaglutide is cheaper,
Right.
right? So because it's cheaper, I'm willing to prescribe it as an option, and it still works. It works very well for these patients.
Yeah.
But I actually really like that idea that like I have that option, because tirzepatide is like kind of, it's the Cadillac,
Right.
right? And there's no harm in having a lesser expensive medication for patients who need it.
Yeah. Do you ever prescribe oral semaglutide?
What is it?
Ribelsis?
Ribelsis? I have not.
Okay.
I have patients who have asked about it, and I'm
It's
going to be.
very expensive too.
What is it?
Extremely expensive.
Really?
Yeah.
So I mean, none of the patients I have spoken to are willing to throw money like that around. So
Yeah. And a lot of side effects too, nausea and constipation, especially at the higher doses. But I think if you're going to do it, do the injectable form.
have you prescribed it?
Mm-hmm.
Yeah.
Mm-hmm. Yeah.
So the side effects. So I imagine it's got first pass, so it's probably less effective, right?
Yeah, it is.
And I know that studies that were comparing the oral semaglutide versus injectable was not as effective from a weight loss standpoint.
Yeah. Yeah. Where do you see the future in this ultimately? Do you predict that hopefully it's going to be more affordable for patients? Are doctors going to continue providing this? Are we going to see some consequences later on? What do you predict?
I have so much thoughts about this. I think that the road is already paved for what this is going to look like. The way you have to look at it is you look at the big companies, the Hims of the world, the Hers of the world, the Roes of the world. These guys are pumping medications out like
And they're capitalizing on it.
Crazy, right? Like, Serena Williams coming out on there. Meanwhile, her husband's like the main investor in Ro, right? She comes out there. Ro puts so much money into their marketing. Okay. What do? They provide the exact same thing we're doing, just honestly lower quality because they don't have me and Air doing it. Right. They send it out the same price. It's not the same price, more expensive. But what's going to happen when the price goes down?
Yeah.
What they're going to do is they're just going to put another medication in there. Because if you look at the arsenal of what Ro and Hims has, I mean, Hims has sildenafil, right? Viagra, generic Viagra. It has, what is the topical finasteride and minoxidil, which is for hair growth, right? That's all these things are generic medications. Generic medications means it should be $5, right? But they're sending it to you in an $80 vial, right? They're sending sildenafil. Oh, it's so easy. Look, the shame of the doctor. $100, right? So, what they've paved is this ability for access,
right?
And they're gonna just keep adding medications to it,
right?
And why that bothers me is that this stuff all has side effects, right?
I mean, under a blanket of, we are doing our due diligence, we're doing the assessment. Meanwhile, and I've actually filled out the application online, you don't really interact with anyone. It's just you're submitting the paperwork and someone behind the scenes is either approving it or denying it. But I'm thinking 99% it's approved. You put in your credit card and then they ship out the
I'm going to tell you the truth. One time, and I have a nice full head of hair. Unfortunately, knock on wood. But my wife looked at me and she's like, saw like a part go on the side and she's like, "Are you losing your hair?" Next thing I do, I join up to Hims. And I did the exact same thing. No provider saw me. No provider talked to me. No provider gave me any guidance.
I saw a physician's name on it.
Well, yeah.
But
and they saw the picture, right? And then I clicked on it. 10 days later, I get the medication. I get sent to me. I spray it in my hair. I get a reaction to it, right? I call them, no response.
Yeah, of course.
No idea what they're going through.
They already got paid.
Yeah, and then I talked to the pharmacist there, and the pharmacist is like, "I don't know what to do." And then I was like, "Do you know the side effects of these medications?" And they're like, "Not really."
Scary.
And I was I'm like, "Why do you guys send this stuff?" So then I canceled it, and they still kept sending it to me.
Yeah.
Of course, I'm still getting charged a fortune for this stuff. So
once you're in, you can't get out.
Yeah. So then I that model is so bothersome because that's not medicine. That's just like keeping you hooked to something,
Right.
And a subscription service. So I think, like you said, the future is strong in that people are going to ask for it and there's going to be avenue for it. I think there just needs to be like a conversation in the public of like, is this the appropriate avenue for it?
Yeah.
Like we were talking about, HRT. I'm going to tell you right now, eventually in hers, HRT is going to be part of it.
I'm sure.
You're going to have estrogen creams come through
Sure.
because the black box warning is gone.
Well, and already the advertisements have already started coming again on.
Oh, really?
Brand. Yes.
I got to watch more too.
So it's scary.
Yeah. So that's the problem with this. You take off the warning. Capitalist America does not have anything holding it back.
Yeah.
And the problem happens when we have gatekeepers not in the best interest of patient care managing that, then there's nothing holding them back. The floodgates are open, right? And so, time will tell.
Yeah.
Side effects are going to happen. People are going to get harmed, and then they'll go back and be like, oh, shoulda, woulda, coulda.
Well, I think in summary, GLP-1s are here to stay. I think it's been revolutionary in how much this has helped patients. Yes, they may have their limitations, but I feel it is truly a game changer in people who've struggled with weight for many, many years. I'm hoping that it will be more accessible in the future just through the right means, right?
Yeah.
And I'd be remiss if I didn't also include, from my surgical friend's standpoint, it is so important for patients to discontinue this at least 2 to 4 weeks prior to any surgery. So many anesthesiologists have commented aspiration events and so it is so important if you're on these medications to really stop them before any type of surgical procedure.
It's a great point.
Any other thoughts?
Just eat a little bit more. Like if you're on the GLP-1s, just make sure you don't.
Yeah.
Like make sure you eat.
Yeah.
That's important.
Yeah. GLP-1 medications have changed the game for a lot of people. They're powerful, they're effective, and they can absolutely be life-changing when they're used safely and, of course, responsibly.
But like we talked about today, they're not magic. They're not a shortcut. And they're definitely not something you should be injecting from a random vial at a med spa. Patients deserve proper screening, proper dosing, proper follow-up, and a real plan, not a syringe and a good luck. If this episode helped you understand this whole world a little better, hit subscribe, leave us a review, share it with someone who's considering these medications, and as always, shout it out from the rooftop. And if you're in Tampa or Las Vegas and want a GLP-1 weight loss program that's actually supervised, medically sound, and built around safety, we'd love to take care of you. In Tampa, visit us at Seth Premier Medical. And in Las Vegas, see Dr. Parker and his team at Parker Medical. All the links are in the show notes below.
Thank you for listening. We'll see you on the next episode of Out of Network.